Well, thank you all so much for having me. This is a hard platform for me to do this on, and in WebEx, I like to be in person, but I appreciate y'all being here, and I hope you enjoy the talk. I am, here at Children's. I'm around a lot, so please, my info's at the end. Feel free to contact me one-on-one if you have questions. Whether they're, personal or not, that's fine too. As you know, you may be filmed or photographed. We are recording this presentation. I'm actually the only one kind of on image. And disclosure statement, I do not have any conflicts of interest or discovering any off-label product use, no commercial support or sponsorship. And then this is my own kind of addiction counselor disclosure. When you talk about drug and alcohol use and abuse, people can get kind of defensive. So just so you know, I'm not here to criticize, diagnose, judge your own drug or alcohol use. I'm primarily here to talk about youth. So no need to worry or start to self-diagnose or anything. If you're an adult, you're over 21, you're free to use drugs and alcohol, especially in the state of Washington, ones that are legal, and that's your business, or, even the ones that are illegal, that's also your business. So, no need to kind of get worried about those things. We're just really here to talk about youth. So no worries there. The objectives, we're going to go over, review the Diagnostic and Statistical Manual of Mental Health Disorders for Substance Use Disorder. I can't go over every mental health diagnosis, but we can kind of look deeply into that one. Talk about the latest drug trends that are, especially the ones impacting youth, so marijuana, nicotine, and we're going to touch a little bit on opiates, but I know a lot of y'all here already know a lot about opiates, especially if you're in the nursing profession. Discuss some co-occurring substance use mental health disorders, describe some treatment options for substance use co-occurring disorders, and especially the latest uses of Narcan and how to get that in King County. So we'll get started. I don't know if everyone here is a nurse, but I do have to say I have a lot of respect for nurses. I've worked in emergency departments and hospitals and schools, and they're just some of my favorite people. So I'm really happy to be here. But we're going to jump right in. And so substance use disorder, it has 11 criteria. And according to the 5th edition of the DSM, it is diagnosed as mild, moderate, or severe. So mild has meets 2 to 3 of these criteria, moderate 4 to 5, and then severe 6+. And so 6+, that's going to be what we're kind of thinking of when we think of addiction, dependence, someone that has a really serious addiction. And then mild, moderate, especially mild might be more of someone that's abusing substances and we're maybe not to the point of addiction. I won't get into what I think of the DSM, but we're going to jump right in. I agree with some of their stuff, don't always agree with all their stuff. So this is where our poll is going to come into play. So I need y'all's help, or at least to humor me. So the substance use criteria are based on physiological, psychological, behavioral, and functional impairments. So as we go through these criteria, I want y'all to tell me, and again, there's no right or wrong answer. I'm not going to pop up with one because some of them meet kind of all of them. But I want you to tell me with this criteria, which fits best. Is it mostly physiological, mostly psychological, or mostly behavioral and functional? And we're going to try to kind of go through this a little bit quickly. So just kind of, what are you leaning towards the most? So, mine is doing that. So let me, okay, so we'll do this. The substance is often taken in larger amounts or over a longer period of time, a longer period than intended. So would you say that fits the best criteria for physiological, psychological, behavioral, and functional? We got some people voting. And again, just kind of best one. All right, so we got a lot of votes for behavioral and functional, and I would say I agree with that. I think the word that gets me here is that word intended, right? So it's taken in larger amounts over a longer period of time than it's intended. So I went to a party. I was planning on drinking 2 drinks, but I drank 4. And so there's this kind of intention that you go and you're doing that, and it's not really like there could be there's probably some physical drive there, but there's also kind of this like psychological and actual behavioral functional kind of thing going on. All right. So our next one, there is a persistent desire or unsuccessful efforts to cut down or control substance use. So again, is it best fit physiological, psychological, behavioral, or functional? A persistent desire or unsuccessful efforts to cut down or control substance use. All right. Oh, we got some stuff going on here. I like it. Lots of different opinions going on. 13, 14 people voting. All right. I think psychologicals kind of winning out on this one. Behavioral functional kind of second. Physiological coming in, respectful. Oh, this is a little behavioral functional going. I think, yeah, these are tough, right? But there's a desire or an unsuccessful effort to cut down or control the substance use. Again, I think they all kind of come into play, but there is a desire. There's a trying to stop. There is this behavioral, this psychological component there. That's going on. This one's always interesting. A great deal of time is spent in activities necessary to obtain, use, or recover from the effects of the substance. A great deal of time is spent in activities necessary to obtain, use, or recover from the effects of the substance. So we got a couple things going on in there. How many people we got voting? A lot of behavioral and functional, some physiological, psychological. I love the live poll. It's really fun. So we got kind of behavioral and functional in the lead, looks like. And I think you're all right there. We've got the, necessary to obtain, use, and recover. That's kind of where I get that physiological thing. But yeah, obtain, use, you're spending your time. There's a behavioral action there. You're making the choice to use. So there's that piece there. And then we get to our fun one of a craving or strong desire or urge to use the substance. So what does that fit best? Is that physiological, psychological, behavioral, functional? Craving or strong desire to use the substance. No, physiological and psychological are fighting it out. This one. And physiological is going to win. What's that? I think it's going to win. Yeah, we got a lot of people voting. Y'all are doing a good job. Yeah, right. I mean, craving is always so interesting because I've heard this, for a long time, people have recognized the craving for use as something that is really connected with like addiction and substance use. And I always think of kind of too, like that piece that we talk about it in mental health where you have the lemon, right? And if we all think of a lemon and we think about cutting the lemon, and then we just think about sniffing the lemon, and then we think about licking the lemon. And for some of us, like our mouth can start to even salivate just thinking about licking this lemon and it's sour. And it's just like, what's physiological, psychological? I'm thinking of something and my brain, my body has a physiological reaction. So it's just interesting how intertwined they are. All right, thank y'all. The next one, recurrent substance use resulting in a failure to fulfill major role obligations at work, school, or home. So recurrent substance use resulting in a failure to fulfill major role obligations at work, school, or home. So this one's looking pretty unanimous. It's pretty behavioral functional kind of thing. Got a good amount of people voting. And I think that one is pretty straightforward. A lot of these are not, but that one's pretty like not able to fulfill obligations at work, school, or home. This one we're looking at, we've got continued substance use despite having a persistent or recurrent social or interpersonal problems caused or exacerbated by the effects of the substance. So social or interpersonal problems caused or exacerbated by effects of the substance. So see what people think here. Psychological, behavioral, physiological, and kind of all three. Yeah, kind of psychological. Yeah, this is one I work with a lot. You know, especially with parents having issues with their kiddos, and you know, using, or you know, even being in the schools, friends having issues. So 7, important social, occupational, or recreational activities are given up or reduced because of the substance. Again, kind of a more straightforward one right there. This one's always interesting when you confront a kiddo. Oh, we got some psychological too. Yeah. When you confront a kiddo and you're kind of like, you're not, you know, playing soccer anymore. You're not doing this. And they're like, well, I don't want to do that anymore. And it's like, but especially when I worked in schools, I'd be like, I've seen you for years. Like, I know I've seen you in a soccer jersey every day for 2 years. And now you're telling me you don't like that. You know, I find it hard to believe. So, you know, sometimes those things take over. Recurrent substance use in situations where it is physically dangerous. So putting yourself in situations where it is physically dangerous. So we've got some behavioral, functional, psychological, physiological. It does have the word physical in there. Right. So yeah, right. This one is a good one. I think we got a lot of behavioral functional ones on that one, because you're putting yourself in this position where you are in danger. And that can really, you know, it can happen, and happens a lot, especially with youth. And so this is the last one we're going to do the poll on. I'm going to review some of these. And I know there's 11. I do know that. But the substance use is continued despite knowledge of having a persistent or recurrent physical or psychological problem that is likely to have been caused or exacerbated by the substance. So continuing to use despite knowledge that you have diabetes and you should not be drinking alcohol, you are making your problem worse, or you have psychosis and you should not be, you know, using cocaine, but you are anyway. Continuing to use, we call it, just kind of the overall definition of addiction is continuing to use despite negative consequences. So seeing a lot of split here. Yeah, because there is got a physical problem, got some psychological problems, but there is this kind of continued desire to use. So kind of split on that one. I think that one, I agree. I think that one's kind of all of them in one criterion. So I have some more people vote, but I think, yeah, that's good. I would kind of agree on that one. It's kind of all of them, but kind of the knowledge he kind of gets it for me there sometimes, or just kind of continuing to do this. Well, thank you all for participating, like having some interaction with you on this. And so I do that to kind of go over, we're going to kind of review these again to just get an idea of the criteria and to really get an idea of there's addiction and how we look at it. Because when I diagnose someone, it's not just how often you use something. It's really about how it impacts someone's life. And I've done a couple nursing conferences, and so sometimes this comes up, and when I don't bring up the diagnosis, I've gotten in trouble. So I don't make that mistake anymore. But I also wanted to bring this up over one of the drugs we're going to talk about quite a bit, which is marijuana. And so I wanted to review these just 9 criteria at first and kind of look if they can apply to cannabis use disorder. So, and of course, I always tell the youth this when I'd go in classrooms, that y'all are more than welcome to disagree with me. I'm totally okay with that. This feels full of disagreement, so it's okay. But, when we look at marijuana, substance is taken in larger amounts over a longer period of time than intended. Can that happen with marijuana? In my experience with youth, absolutely. I'm going to go to this party, Miss Kirby, I'm not going to use, come see him on Monday. I used. Desire or unsuccessful efforts to cut down or control the use. I talked to 2 youth last week. Kelly, every day I try to not use marijuana. Every day. And every day I fail. Been to hundreds of AA meetings and heard that in the Seattle area. A lot of people that are addicted to cannabis go to AA meetings and just kind of say, I couldn't stop using. I could not stop. Great deal of time spent obtaining it, using it, recovering it from it. We might even know some of these people. Craving, that with marijuana forever. I've always heard about like marijuana cravings. And that's very associated with it. Recurrent substance use, resulting in a failure to fulfill major role obligations at work, school, or home. Definitely something that can happen. I had one kid that kept telling, he was in a long-term inpatient, and he kept telling me when he smoked weed, he got straight A's. And fortunately, he finally said it in front of his dad. And his dad was like, what are you talking about? You never had straight A's. And it turns out it was just for 1 week. And so it never actually made it to a report card. And I was like, okay, please, I don't want to keep hearing about the straight A's anymore. But, obviously it can impact that. But for some youth, they're really good at, they can use drugs and keep functioning. So not everyone. Continued substance use, interpersonal problems, absolutely. Work with a lot of parents that are very, concerned about use, bothered by use, all kinds of things. Social, occupational, recreational activities are given up. Like I said, I have youth all the time, and a lot of times parents will be like, you used to do this and this, or you have different friends, and all these things change. It can absolutely happen with marijuana. Recurrent substance use in situations where it's physically dangerous. The marijuana and driving comes to mind. I hear about that a lot. I hear a lot about how I smoke better when I'm high, all these kinds of things. And I just have a hard time believing that's true. But, I still have a lot of female clients that, just like they with alcohol, put themselves in dangerous situations. With marijuana, the stories are very similar as they are with alcohol, or sometimes they're mixed. Substance use continued despite knowledge of having a physical or psychological problem. I have I have a lot of slides with a lot of information and, an hour. So I do have a slide on the cannabis hyperemesis syndrome. So, we're seeing this more and more, as I'm sure y'all have, of youth, that kind of are developing this allergy to marijuana, and they're getting sick from it. And the biggest issue I have is that they have a hard time stopping use, to the point where, I end up seeing them on consult service, and they're just like, I don't want to be in the hospital again. but they keep using, or they are having like an anxiety or they've been in the PBMU for psychosis, and they know it was marijuana induced, but they keep using. And so I see those kids now. I realize I'm one person and working in one place, but there is some literature to back it up as well. Our last two criteria, I figure y'all already know about: tolerance, need for more and more to get the desired effect. And that, I believe, can definitely happen with marijuana. That's just part of why, I try to find out, how much did you use at first? What's the most you've used? How much do you use now? And typically it's more than what they needed at first to get the desired effect. And then the withdrawal. And this was always kind of the sticky piece, right? Like you don't withdraw from marijuana, so it can't be addictive. Well, according to this, I don't need it. I got 10 other criteria, and I only need 6 to diagnose you with a severe cannabis dependence disorder. So I don't need this one. However, there is marijuana withdrawal. It used to happen when I worked like inpatient substance use. We used to see it kind of delayed, like once the THC was kind of out of the bloodstream, you'd start to see this kind of irritation, irritability, craving, those kind of things come like 5 to 7 days. I'm starting to see it a lot sooner now, and I'm starting to have youth like tell me about it. Like I'm used to have to argue, go, well, maybe, I don't know, you might have some, and now they're like, yes, I'm having withdrawal. And there is even a diagnostic criteria for cannabis withdrawal. So I'm not going to go through all this, but there is actually something I agree with the DSM on. There is a cannabis withdrawal, and a lot of it you can see is irritability, sleep difficulty. I have a lot of youth that were really deep into marijuana, and they keep using it because they can't sleep without it. Their appetite is hard. They can't, they have a hard time eating without it. So it's definitely, again, not everyone that drinks alcohol is going to be addicted. Not everyone that smokes weed is going to be addicted, but there's a group that will. And I see a lot of those youth. So it's something I'm very concerned about and passionate about. And I know y'all are on the front lines, so you see a lot of things too. Part of why I believe this withdrawal is getting bad, I think there's a lot of issues with cannabis. We're going to move into our drug trends, is the potency. And the potency is getting higher and higher. I'm sure y'all have heard about this. Our markets are just dominated with high potency cannabis, the Delta-9 tetrahydrocannabinol, THC, and then the cannabinol CBD that we now know about. And a lot of what's happening is the THC is going up and the CBD is coming down. And that's kind of not the good balance we want. And we're seeing a lot of, psychotic symptoms and anxiety and a lot of things in adolescence. I did add this from the DEA. Now this is, I like this slide because it's the longest one from 95 to now, from when I graduated high school at 17. But this is from seized. This is from what's like illegal cannabis, flower cannabis coming into the country. And as you see, so like back in 95, we're at like about 4% THC. We still have a higher percentage of CBD in it. And, you jump forward 10 years and it's doubled, but we still have an okay amount of CBD. You go down to where we're kind of legalizing it, in the 2010s, and it's kind of tripled from 95, hasn't quite doubled from 05, but it's getting higher, and then the CBD is getting lower. These are partially because of like how it's grown and those kind of things. Has a little dip, but it's still pretty high. And I would say like even 15, 14% is still high. If you saw the article, Dr. Chow, and I was like, it's not your granny's weed. It's not even your big sister's weed. This is like, but this is what the government seizes. this is not what's in our local pot shops. What's in our local pot shops is super potent cannabis. So when you go there, when you can, and you can look at it online. I didn't put it in my presentation because I didn't know about if I should or not. But yeah, I got this next slide. But when you go and look in there, you can look online. I looked at several shops around Seattle, and pretty much the lowest flower that I saw, we're going to talk kind of the different ways they use it, was about 10% THC, was kind of some of the low end. Most of them were around 20. That was kind of more of the average. There were some 14, 16s. The highest I saw was 30% THC. The Liquor Cannabis Board is looking, and the legislature, they kind of want to tax the higher potency cannabis. Right now, they're pretty pretty much the same cost. So I was in a training once for marijuana, and there was a lady in there, and her family owned a marijuana shop, and she was a little saucy, but I was glad she was in there because she was real helpful. And she said, we have the higher potencies because that's what people want. So we don't stock as much of the low potency because people don't buy it. And so sometimes it's a little bit more expensive. And I mean, just like $5 maybe, but she said they just don't stock as much because people don't buy it. They buy, not always the 30% THC, but they're buying around the 20 to 22 is kind of what's popular. So, that's kind of what's been going on. Now you can get some that's got the lower THC and the higher CBD, but there's not a lot to choose from. That's with the flower. We're going to talk more. We've got the route of administration. So there's smoking, it's kind of the classic way that it's used. Vaping, dabbing. I'm going to get more into these. The edibles, drinkables that y'all probably know, the creams, the oils, the dissolvables, are all there. And when we get into the nicotine, I'll actually really break down the vaping. So if you're not super familiar with what that looks like, I'll make it very familiar. But I will get a little bit more into the vaping and the dabbing and kind of what that looks like. And from 2018 to 2019, the kind of survey data with most high school seniors is that the increase for vaping doubled. So we don't have good data for 2020 because a lot of youth weren't in school. So we just don't. It's hard to get good survey data. Hopefully this year we'll get some better data. The vaping seems to have really increased a lot. And when I ask my youth a lot, I talk to them and I'm just kind of like, how do you use the marijuana? And typically what they tell me, not typically, I mean, I think almost always it's I smoke, I vape, I dab, and I have edibles when I can get them. And typically they really seem to like the vaping and the dabbing a lot. And I have had some of them try the oils and stuff and even the straight CBD. And I'm always surprised. I always ask them just for my own kind of polling and curiosity. And they do kind of like the CBD. But I'll tell you what one of my patients told me to tell y'all. But anyway, so I'll get into the vapes. These are the concentrates. They're extracting the THC, kind of getting these oils. And the youth, they call them carts. So these are really easy to use. They don't smell. You got to work to roll a joint, work to roll a blunt, work to pack a bowl. You don't have to work to hit a cart. You just kind of take a hit of that. I put in this picture, I had limited pictures. So I did put these are nicotine ones that I'm going to show you later, but I just wanted to give you an idea that this is what they typically kind of still look like. These are older looking nicotine ones, but this is typically what the marijuana ones still kind of look like. And they do call them cartridges. And they're mostly high in THC. Again, I could find some of them with really low THC and 2% THC, 11% CBD. I could find some of those. but a lot of them were in like the 70s or 80s. So like if you go online and just kind of look up what they have um, around Seattle, it's going to be a little bit higher. Um, and a lot of youth, they use what they can get or what they can buy. Um, and so this can go up to 90% THC. I do have one of my patients. So I was telling him about this presentation, and he got one of the lower THC ones, and he was on telemedicine with me, and he was using it, and that's why we were talking about it, and I wanted to hear about it. And he's like, you need to tell them at your presentation, ain't nobody interested in CBD. Ain't nobody. And I told him I'd tell y'all, but I was like, I don't think that's true. I said, I've got some youth that said they don't mind the CBD. And he's like, no, because he wants to go back to the full, higher THC carts. I don't want him to do that. But he said, no, nobody interested in the CBD, because he was not enjoying it that much. But they are available. His mom got them for him. These box mods in this picture, just keep that kind of in your head. Those are still kind of used with a lot of marijuana, and you can put a lot of different things in there. I'll talk about those in a second. The dabbing, you haven't heard the dabbing. This is the extracts of like the hashish oil, and created using a butane solvent. So it's like the butane hash oil that is used. These you can, fortunately, in some ways, vape now. Before you couldn't. You had this, like, y'all might know about this better than I do. It's back like when, after this kind of, sometimes to me, the dark side of legalization, and you had this like big pipe, and it had like a nail on it, and you took this really concentrated like shard or whatever, people call all kinds of different things, and you put on there, and you'd almost have like a blowtorch lighter to light it, to heat it up. And it was just really scary. And it was getting really scary, and like worried people were going to burn their house down and stuff. Wasn't a fan of that, but then they pretty quickly moved to being able to make dab pens. And so you can do it normal, kind of like a vape. It's just a different concentrate. Or you can actually take like this, like shard, butter, shatter, honeycomb, and get a special device. Here's my faux pen. It's just a real life pen. But you can actually like open it up, put it in there, and have that actual like dab in there and use it. There's tons of YouTube videos out there, sampling, unboxing, trying it. They come up in my feed because I watch some addiction doctors, when I'm looking up some of this stuff, and then they'll be like the new dab, and I'm like, oh, good Lord. I put 50 to 90% THC in here. When I was looking this up in Seattle, there's some 95%, 93%ers out there that get into the dab. So this is really potent. And to me, we're moving further away from this plant that's, all natural, that, okay, we're lighting it on fire and smoking it, and we're putting smoke in our body. But then when they were working on legalizing it, I would sit on these panels with, Pete Holmes and these other people that wanted legalization, and they would go, we want people to vape it. And I didn't even know what that was at the time. Now it's like my whole life. But they would go, we want people to heat the plant. And you can do that. I never hear of youth doing that. I've asked that they don't hardly even know what that is. So you can vape the flower and kind of do that. But it seems like people still will traditionally, if they're going to use that, they'll still smoke it. But this dabbing, it seems like we're kind of getting further from what is actual marijuana, because you have to extract, you're using different solvents, and it's just not seeming as pure to me. You can have your own opinions. Again, more than welcome to disagree with me anytime. I did want to mention this to y'all. I have not seen this with any of my patients in Seattle. Of course, I'm here at Children's. I'm not always out where, always the latest is going on. But there are some trends with some different Delta variants. So when I say THC, I'm usually referring to Delta 9, tetrahydrocannabinol. There's some Delta 8, Delta 10, Delta O, or Delta 0 variants out there. This slide primarily deals with the Delta 8 issue because our LCB, our Liquor Cannabis Board, I think Washington State has kind of outlawed it, but because the Farm Bill kind of accidentally legalized all these different forms of hemp. So this THC Delta 8 is a naturally occurring cannabinol, but the process of extracting it is not very natural. So there's this Delta 8 vape cartridge. So I told you to remember that box mod. A lot of times people vape them in these type of box mods and you put them in there. But you can do it in a regular vape as well, or they have the gummies and stuff. And so for a while, and still in some states, these are sold in like gas stations because they can get around the regulations because it's not, a lot of the laws are written with Delta 9 tetrahydrocannabinol. So there's just stuff like that out there, and it's concerning for me because youth don't always stop and go like, whoa, what is this? They just get access to it. And they're willing to try it. And again, YouTube, tons of videos on this. I was just looking on there today, more because I hadn't looked into the Delta 10 as much, and there's a bunch of videos on there, people trying it and getting super high. And so it's just a concern. I don't know, like I said, I haven't talked to any youth that are using this, haven't even heard about it that much in Seattle, but it is out there. And these are concerns, and you'll see why if y'all heard about the EVALI last year, or more in like 2019, where people were hospitalized from vaping. And a lot of us in the community kind of thought like, okay, this is it. This is this is what cigarettes are going to do to all of us. And really, we found out later when we kind of stopped having cases, it was really from these counterfeit and illicit carts that were being sold. And they had this vitamin E acetate, and people were getting sick, going to the hospital, dying. And then once that was found out, they kind of disappeared from the marketplace, but there's still a lot of these illicit carts out there. So it's just a lot of people in the addiction community are saying like, these different Delta variants are going to be, or not Delta variants, COVID, but these different Delta 10s, Delta 8s, I mean, they could cause another outbreak. So there's just things to be concerned about in the community. Again, I said I'd touch on the hyperemesis syndrome, and that is a cause. I'm seeing it more and more. I saw one case in 2009 when I worked on our substance abuse consult team with Dr. Walker Harding. And the thing that stood out to her was the patient needed to take hot showers. But we had a really hard time convincing them that they had this. So we kind of had to just let that one go. But I've seen this a lot this last year being at Children's. I've seen it outpatient, inpatient, other clinics have called me about it. So this is out there a lot. And then I did want to touch on like cannabis and kind of just specifically with mental health. And, we often use drugs to kind of change our mood, fun, experimentation, sometimes boredom, but, often to kind of cope with feelings. And, you hear the word self-medicate, these things. And as y'all know, I know you're medical professionals a lot of times, but, the teenage brain is developing and it's growing. And it's really detrimental because we really want our youth to use their coping skills and develop those pathways and not use drugs. And marijuana it's a pretty powerful drug. And so this little line down here, you're like, what is this crazy line? Is what I used to it's kind of a short example of what I would do with the youth when I go in the classrooms, but they always kind of liked it. And I would explain it to them. And sometimes I do it on video with my hands and stuff. But I always kind of use this line as like, this is our baseline mood. Like, kind of like, okay, not, when you see someone, how you doing? Fine. Nothing great, nothing that bad. And then sometimes we're kind of feeling low or down, or having a bad day, or we're really nervous because we're doing nursing grand rounds. And so we're, I don't know what to do. And so we have to settle ourselves and, use our coping skills, and we get some coffee and we talk to our manager, and we get with, uh, Lena and Hyann when they're sweet, and we, chat and calm down, and then we're kind of back at baseline, and then we do a fun poll and we're good. And then, yay, nursing grand rounds, I survived and it's all good. And then we kind of, go back to baseline. And so when I tell, my youth is when I'm low or when they're low, I want them to use those coping skills. But if I take my fake vape and I get high, then I've bypassed all of that work. And I feel even better than I would even after accomplishing my goal. And I just feel good. And if I do this again and again, I'm creating a pathway in my brain that isn't very healthy or realistic for the long term. And they would kind of understand that because, caffeine is my drug of choice, but, it's not quite as powerful and quick acting. It has 7 seconds to my brain as marijuana. So we really kind of want them to put that off, want them to wait until 18, 19, 21 when it's legal, later if they can. But I do at least try to move them towards, putting off that first use or any use or continued use as long as possible. And sometimes I'm kind of just going, I want you to just be an adult that doesn't have to deal with addiction or deal with abstinence. I want you to have a healthy relationship with drugs and alcohol. And so they often want that too. And so that's just one way I kind of explain to them, because then what happens is, I did put the tail line in there again, my baseline. So then normal no longer feels good, and I need to kind of feel elevated all the time. And I have a lot of kids tell me like normal life is just boring, and they have a really hard time dealing with that. So it's kind of part of what we want to avoid. I did tell you I'd kind of break down the vapes for you a little bit if you're not familiar with them, which I'm sure y'all kind of are. But if you don't know, they kind of have these components of a battery, a heating element like an atomizer, and a cartridge tank, a mouthpiece. And if you notice, like this one is a little older one, it has a power button, but typically a vape like will light up, and that's signaling my brain I'm going to get a treat, right? And so, they're very techy. Typically, the tank's going to have liquid, nicotine or marijuana. And then they'll have some like propylene glycol, but vegetable glycerin to help aerosolize this, because it's an aerosol. It's not, I tell my youth, I'm like, it's not me just boiling water and giving myself a facial. It's an aerosol. It's got flavoring. It's got, all kinds of chemicals can be in there. Not well regulated. And now that they're salt-based, they have this benzoic acid that allows for a higher concentration of nicotine, and that gets into your bloodstream faster and then leaves your bloodstream faster. I feel like we've heard this story before with nicotine products, where there's this kind of, use issue. So here's kind of our history of the e-cigarette quickly, kind of compare it to the flip phone, to the iPhone 11 or whatever we're on now. But as you see, like originally they were really marketed as a smoking cessation product. They looked like cigarettes. What we found is they don't work well as a smoking cessation. They do work well from turning people from smokers to vapors. And I've got some stuff on the next slide about that. But for stopping nicotine altogether, not the best. Would probably recommend a gum or a patch, or, going to the doctor for prescription, or working with the quit line or something, some combo or something different than starting here. But if you want, they're good if you want to switch. Then we kind of got to these vape pens, which started to worry me, because they were all like glittery and sparkled and had characters and had flavors for them. And I was like, who are you marketing this to? Then we had these box mods that, again, are still kind of used in marijuana. And then the granddaddy of them all came out, Juul. And this is when they started the salt base, so they could get more, higher concentration of nicotine into a smaller packaging. Looked really techy. We all, like tech, right? And carry tech around. Then they had, kind of these, there's a ton of different, companies out there, these pod vapes, and then these salt-based ones that were disposable. Like, why go to disposable? You have this Juul with these pods, because they could get around the flavor ban with the disposable ones. So that's just kind of what is out there now. And unfortunately really popular with youth. These are just some studies y'all can look at, but like there's some evidence out there that if you switch from traditional cigarettes and you completely switch to electronic cigarettes, there's possibly some some health benefits, some respiratory symptoms that go down related to this. So there's some evidence of that, but this third study here, the cardiovascular impact of electronic cigarette use, very clearly warns, as does the CDC, if you do not already smoke traditional cigarettes, please do not start smoking electronic cigarettes. They are not safe. They are not harmless. We do not know what they do. It's 2021. I don't even know anyone that has consistently used, electronic cigarettes in their current form for like even 10 years. A lot of them people now are using the salt-based ones, and that's, 5 years maybe if you started at the very beginning. There's so many changes so quickly. And unfortunately, these are really popular with youth. So the e-volley break kind of did like scare a lot of youth. And so that was kind of a good thing. So hopefully we'll be able to decrease some of those numbers. I know y'all know a lot about opiates. You're, medical professionals. I did want to do some info on opiates, and I did choose to use the King County numbers. These are pulled yesterday that are up from 2020 and 2021 significantly, unfortunately. But the reason I wanted to show y'all this is I took a training. It was really good because someone said, we don't really have an opiate problem in King County. We have an overdose problem in King County, just in general. Because when you look at this, the red is pretty still significant, and that's stimulant, no opioid. And then the purple is opioid and stimulant. So obviously, like the purple and blue is pretty big. So, the opiate is significant, but there's a big stimulant use as well. So that's going on. And so, I do let people know, like, a lot of the street drugs contain fentanyl. Obviously, when you're thinking Vicodin, Oxy, the heroin is often cut with fentanyl. They say the black tar isn't, but I wouldn't trust that information. I just assume it's got fentanyl in it. But it's not just the opiates. It's the meth, the cocaine, the ecstasy, the Xanax, and other street drugs. Even if people are selling their Adderall, it could be cut with fentanyl. They're cut with fentanyl. The King County is still worrying about these M30 pills. But I'm like, if it doesn't come from a pharmacy, and people will take pharmacy pills and they'll sell them to, using that and go, oh no, this is my grandma's Xanax. I don't know. The links there, I did want to put that King County finally started releasing their deaths under 20-year-olds for under 20. And 2008 to 2018, they are single digit. And I'm talking like mostly 4. There's one year, I think 2010, it's like 7 is the highest number. There's one year it's a 6, a few with a 5, but it's mostly 4. And then we get to 2019 and we have 13. And I was working in the schools at the time, and it was a rough year for Seattle Public Schools. And then last year, 23. And then this year, I hate to put the so far there. It hurts my heart, but it's 20, and then we're just into September. So this is a lot. And so that's part of why there is this new Laced and Lethal program in King County. And they are sending out, and I was gonna get the box I have here, Narcan. So that's the the naloxone that you can actually like do the nose spray. It's available at all pharmacies. For Medicaid, they can just go and get it, and they don't have to pay. A lot of insurances they will, charge, but they can, if there's an open, script. But you can, if a patient's in King County, they can confidentially order it. So this has been kind of good for like our outpatients that aren't coming into our clinic, and we want them to get Narcan. They can have it mailed to their house, and so they can do that, and it comes in plain packaging. I did this just to test it, to see if they really would send it to my house, and they did. But what I do ask people to do, and I ask parents, because usually the parents are ordering it, I'll be like, if you can, order it either in your kid's name or at least with their age, because it's trying to combat this under 20 and under 18. So, that's kind of part of how they get their money. I unfortunately don't have any kids, so I couldn't put anyone's, I had to put my age on there and everything, but the links are on here, and it really does work. I know the hospital's working on getting better about giving our Narcan and getting this out in the community, because it's just so dangerous. I am checking time. We're almost to 1 o'clock. So I did want to just touch base on co-occurring disorders. I got a chicken and egg there because, so sleep issues, mood swings, difficulty in school, arguments with friends, siblings, family, trouble, keeping a job, changing, stopping activities, impulsive behavior, changes in clothing appearance. Is this mental health disorder, substance use disorder, or being a teenager? Right? There's so many, like, it's so hard to suss out, there's just so many things going on. And co-occurring disorders, substance use, mental health disorders, there's so many things that go into them. Temperament, genetics, family history, environment, and they really can often progress without treatment. I mean, if it's a true mental health or substance disorder, sometimes a lot of parents think it's a phase. And my encouragement to them is to always to seek treatment, and that parents can seek treatment. So parents can either get into their own counseling or like find someone to talk to about their kids. So they don't always have to just send their kid to counseling. I don't really like to always force kids, and I want counseling to be a pleasant experience, or in some way a choice. In substance use, it's often treatment or jail. And that's not a great choice, but it's a choice. And it's one that's had a good bit of success. Again, a lot of people can disagree with me, but it's there. And so, but don't forget, parents have to forget there's still a lot of training classes out there. There's still a lot. So, there's overlapping risk factors. I hear this a lot, the self-medicating, but then our brains can be changed when we're using drugs. So yeah, maybe at first I was self-medicating, but I've been using this drug for a while. Maybe now I actually am addicted, or maybe I was using this drug and I wasn't depressed and now I am. So these are just things that are really hard to suss out. And so we kind of have this chicken and egg scenario again. And so what I always recommend is treating both, whether it's at separate agencies, the same agency, because sometimes we get, kind of, if we're just looking at the addiction, we forget like, oh, there's some trauma. Oh, there's some other things going on. And then if we're just looking at the mental health, we're like, well, yeah, they smoke weed, but whatever. And they're getting treatment and they're not getting better, and they're not getting better. And that's why like psychosis clinic or our DBT clinic will pull me in and go like, man, this kid, they're just not getting better, and they're smoking weed, and we think that's becoming an issue. And then I'll meet with them and I'll be like, yeah, it's a huge issue. They love weed. They don't want to quit smoking it ever. Like, their main coping skill. And so we kind of want to look at that. But the big thing I want to let you know is that there is a lot of treatment out there, and a lot of substance use treatment. There's abstinence, there's harm reduction, there's a lot more medication assisted treatment for youth nowadays. I mean, 5 years ago that wasn't really the thing, but now they're offering that more often. I don't know how I feel about it. I'm willing, if it works, I'm very motivational interviewing. I'm like, whatever patient is where they are, I'm going to meet them there and I'm going to walk with them where they need to go. I do like to point this out as my kind of last thing. There's a few slides left with a lot of resources. Just in your head, guess in what year do you think the American Medical Association deemed alcohol an illness? It wasn't when they actually declared it a disease, but it was in 1956, and caused by a disease of the brain. In the 80s, they actually, said it was a disease, but and in 1935, Bill Wilson, Bill W. and Dr. Bob started Alcoholics Anonymous, and I think that's had a big influence on the AMA. And I think I just always like to kind of end with, we look at people with addictions, and to different types of drugs, and sometimes we get frustrated, or we do look at it as immoral. Well, I just go and I only have 2 drinks and then I stop. And, we still say these things, even though it's 1956, we're realizing this is a disease. And so we still do those things, but remembering that, there's just, it's very complex. There's a lot of factors. And then when you really look and break it down at the people like in our lives that have struggled with addiction, they're probably some of your favorite people, because a lot of people that struggle with this are really great people. I always point out to the kids, who's your favorite Avenger? Robert Downey Jr.? Yeah, he's Iron Man. He's awesome. He was in jail for 2 years because of his addiction. He went to multiple treatment centers. He got out of jail and relapsed, and went back to treatment and relapsed again. And, but he is finally sober and he's doing awesome. And, our first 27 club, Kurt Cobain and Amy Winehouse and Jimi Hendrix and all these people that were beloved that really struggled with this disease. But yes, they can make our lives frustrating and hard. And that's, sometimes we have to hold them accountable, but that they're still beautiful, wonderful people. And I will, always tell people that people in recovery are a lot of my favorite people. Especially when they're not in their disease or in their addiction. They're just wonderful people. So always remembering that, and not always kind of placing that hard judgment on there. I'm going to open it up for questions. There's some treatment resources on here, some information about Ricky's Law and FIT and available resources, but I would love to hear some questions. So.
And if you want to ask a question, please type your question in the chat using the chat function, and I can ask on your behalf. I'll read them out on your behalf. And while you folks are thinking of questions, I have a couple of my own. So as far as prescription cannabis, can a provider specify the percentage of THC and CBD in what's being prescribed, so that they, so that someone wouldn't get the higher level THC, for example?
So the recommendations for the cannabis, I don't know how strict they are with those. I do have some patients that have gone to doctors. They're not really like my always on patients, but patients I consult about that get that, but I don't think they can necessarily be that specific about the THC. That would be really good though. That would be really nice, especially for the under 21 crowd. But I don't totally know the answer to that one, number one, but that would be wonderful if they could.
I think I think that I just didn't know, and obviously I'm very naive to this because I have a lot of questions about regulation and stuff. And as far as like regulation for the percentage, it doesn't sound like there is a like a regulation, because the range is so wide between 50 to 90%.
Yeah, really, the only regulation is for the edibles. And they kind of, Washington State we did a better job than Colorado of jumping up on that, because at first it was like 10 milligrams per serving, and a serving was like a bite of a cookie. And so they we squash that pretty quick. And it's like a cookie is a serving. And so their 10 milligrams are the percentages per serving for edibles.
Okay.
But that's the only thing that really, has a regulation on it right now.
Okay. And then someone asked, are underage users arrested?
Not in Seattle for sure. They are not. Other parts of the state, typically, a lot of what my understanding, and I don't, work everywhere in the state. Typically, they are not arrested just on marijuana. A lot of times, what happens is they are doing something else, and sometimes that charge is harder to stick. But I can drug test you and know you're 16 and you've used marijuana, and that one will. But I haven't seen a kid in Seattle with a minor in possession for anything since probably 2007. But a lot of places, I don't think they do very often. That I know of. There might be some towns that do, but not regularly.
Okay. And then do the high school teen health center sponsor substance use group meetings?
I used to work in teen health centers, so that's a great question. I think some of them are trying to more. So, like, I know they've tried to have some agencies come in and to do some assessments. So, the first step to getting treatment for anyone, youth or adult in Washington State, to actually get treatment is a substance use assessment by a substance use disorder professional at an agency that is certified to do that. So Children's currently is not. So I'm a substance use professional, but I'm not, we're not an agency that can do that. I can do it at my side job because that's an agency that's certified. So the schools aren't certified, but they can bring in an agency that is. Now they could bring in like a self-help group, like a sponsor, an AA meeting or something if they wanted. I did an Alateen group when I worked at Eckstein, and it was really popular. But some of them are trying to do that. I know they've got some agencies that are certified going into schools, but it's not a regular feature in all the teen health centers. That's not even having like someone that's duly certified like I am in all the schools. So it's definitely a need.
Yeah. To follow up on that, is Children's trying to get certified as?
Yeah, we were at one time. I worked on that, and then we don't have a certification anymore. We are trying to get certified, but just to do at this point, just to do the assessments, so that mainly like our youth, like on the PBMU that are here for a while, that we're trying to get into an inpatient, can leave with that assessment, that recommendation, and possibly go directly to inpatient. Or for people in our medical inpatient that we want to have do the same thing, or to maybe do some next day appointments for people in the ED or something, or even in the clinic. So we are trying to do it, but just for assessments at this time.
Okay. And then any advice on mandatory reporting requirements when the youth are receiving their drugs from parents?
Well, if it's alcohol, there's no requirement because they you're allowed to give your child alcohol in Washington if you want, if it's your child. So that's always
Okay.
a sticky one for my personal opinion. But that, again, the state of Washington not asked me my opinion. Again, I said there's like a lot of disagreements, but so that one, now if they were constantly being intoxicated or something, if they were put in danger, I would do that under harm to self. I have not heard that applies to marijuana as of yet. So, I think I would do it under the guise of safety. I haven't called on that though myself because I'm always kind of leery because I'm a substance use counselor and I'm kind of bound by some pretty strict confidentiality. But I do have a lot of youth that steal from their parents just like they used to with tobacco. Um,
Mhm.
and especially with like the edibles, I really encourage parents to lock those up just like we do with anything, with
Mhm.
opiates and other things, even aspirin. But I don't know. I think that might be a good question for SCAN to see if there's like actual harm being done, or are they smoking with
Mhm.
the parents, kind of are they using with them? I don't know if that would kind of fall under that, like, well,
Mhm.
you can give them alcohol, and if you want to give them, this is a legal drug. Yeah, I'm sorry, I don't have a great answer for that one, but it's a really good question. Might look into further.
There's another question. What is the incentive for lacing substances with fentanyl?
It makes them go so much further. So I can take 10 pills of Oxycontin with like just like two little, with just a little bit of fentanyl can turn it into 100. So it just makes it go so much
Mhm.
further. And so it's money is the incentive. The way I explain it typically is though, if I make 100 pills, 100 oxy that are, laced with fentanyl, probably 90 of them are going to do what I want. Five of them might be duds and five of them might kill you. So that's usually kind of the percentages that I've heard from like people in,
Mhm.
work in King County and in law enforcement, that it's just like a lot of them will just do what they want. They'll work just like kind of a typical um, oxy pill, but yeah, money, unfortunately.
Yeah. One last question. You mentioned that you can order Narcan, and have it shipped to your home. Do you need a prescription for that? Let's say I just want to have it just in case I see somebody who's, um, down and potentially have overdosed.
No, it's what's called an open prescription in Washington State.
Okay.
So you can go to a lot of the local pharmacies. Not all like pharmacies will have it in stock, but a lot of them do, and you can just request it and get it. And like we're I don't know what our insurance is under it. One of our docs tried to get it once, and it was like going to cost them $100. So they were like, I don't know if I just want to have it. I don't really have anyone in my life that I need it for. She just wanted it in case.
Mhm.
Um,
Mhm.
the online one is a free. They will send it to you for free. That's why I just say, like, if you have a kid and you can do their name and age, like maybe help them out because it's under a grant. But so they will send that to you for free. You get a box and it's got all the instructions, everything on it. I meant to bring mine in here and show y'all, but yeah, that one will just do it for free.
Okay. All right. Any other questions so far? This is has been very interesting, and thank you so much for sharing all of your knowledge with us and all of the things the kids are doing these days.
Thank y'all for having me. I hope
Um,
it was helpful. My information's here if you want. I've had people reach out to me questions for, their careers or other things, so feel free to reach out to me if you want to.
yeah, and Kelly will be back in January for our pediatric nursing update conference, and she'll cover more on opioid use then. All right, thank you so much, and we will see you soon, Kelly. Thank you so much.